Let me read these three case scenarios. It said Jane had been a med-surg nurse for nearly 20 years. Recently, though, marital and family problems were pushing her toward a breakdown. So one night at work, she took a Xanax from a patient's medication drawer. It simply helped to ease her tension. So from then on, she took more meds, working her way up to narcotic analgesics. Confronted by her manager, Jane indignantly denied any wrongdoing, and she resigned immediately. Well, over the years, Jane moved through a series of nursing home jobs, quitting whenever a nursing supervisor became suspicious of her. At her last job, she was caught hiding a syringe containing morphine in her pocket. She lost her job, was arrested for possession of a narcotic, and following a conviction, what do you suppose happened to her nursing license? She lost it. Secondly, there's Millie. Millie had suffered from clinical depression. A few days a month, she simply couldn't manage to make it out the door. At first, her coworkers were fairly sympathetic. Lately, though, her unreliability, her glumness, her increasing isolation had become quite an annoyance. After showing up late for work 3 times in a month, Millie was fired. Millie made a weak suicide attempt, taking a small overdose of sleeping pills, and then she called her daughter. The daughter rushed her to the ER, and the ER physician who treated her felt obligated to report the suicide attempt to the State Board of Nursing. And following a hearing, what do you suppose happened to Millie's license? She lost it. And lastly, there's there's Linda. Linda had a bad back. Her disc problems had worsened over the years to the point that the pain made it impossible for her to walk. Her doctors advised surgery, but Linda, a single parent with college-age children, simply couldn't afford the time off. With increasing frequency, she took shortcuts just to make it through her 12-hour shift. On one particularly busy day, when the ICU was short-staffed and Linda was in extreme pain, one of her patients coded. Linda couldn't even get up out of her chair to assist. The patient died. Linda was fired. Her inaction was reported to the State Board of Nursing, and following a hearing, what again do you suppose happened to her nursing license? She lost it. And really that's what ISNAP is all about. Working with nurses who have a substance use disorder, and to the best of our ability, making sure they don't lose their nursing license and their career for having a disease. Let me give you another example that kind of sets the stage. Say you have a colleague who has some kind of a health problem. It could be diabetes, it could be a heart condition, and say that this nurse has a heart condition, and one day while they're working, literally has a heart attack, collapses there on the unit. What do you do for the nurse who's just had a heart attack? Obviously, you get them down to the emergency room, you take care of their physical needs, and what does the supervisor say to the nurse who's just had a heart attack? Take as much time as you need.
Don't worry.
Don't worry.
It'll be fine.
It'll be fine. You take as much time as you need, and when you're ready to come back to work, we welcome you with open arms. Now, suppose you have a colleague who's an addict. You may or may not know that, in fact, the colleague is an addict. Generally, you don't. It's amazing how well they can keep it hidden from the workplace. One day they go into the restroom and they shoot up medications. And just for simplicity's sake, let's say they brought these in from home, from the streets or somewhere. They did not divert, because once you divert, it obviously clouds the issue quite a bit. We'll talk about diversion in a little bit. Goes into the restroom, shoots up and passes out. And somebody says, "Where did Charlie go?" And you say, I don't know. I thought Charlie went to the restroom." So you get security, you break in, and sure enough, Charlie's passed out from an overdose. What do you do for Charlie? Well, the first thing you do is you get him down to the emergency room, and at least you have the compassion to get him down there, take care of his physical needs.
Maybe not.
And then generally, at least in the past, we terminate without question. Now, why do we treat those two employees so significantly different when they're both struggling with a health condition? Well, my guess is it's probably because of our lack of understanding with the disease process of addiction. Paula Skimmick has written a book, Unbecoming a Nurse. Now, addiction is unbecoming of anybody. There surely can be as the addiction progresses. But what's the #1 most highly respected profession in America today? It's nursing. If you do a survey, it's always nursing who we most respect and value. And when a nurse struggles with addiction, it surely can become, unfortunately, unbecoming. She subtitles it Bypassing the Hidden Chemical Dependency Trap. And what she does is she challenges us to take a look at our biases and our prejudices against folks struggling with an addiction, and to begin to treat it with more compassion and understanding, and to get them the help that they need, rather than to simply terminate and send them on their merry way. She's written a second book, From Unbecoming a Nurse to Overcoming Addiction. It's actually 20 stories of nurses who got caught in the throes of addiction, got help, and then got onto the road to recovery and saved their nursing careers as they did that through the process. Why are nurses at a greater risk to develop this addiction? How do they get started to use in the first place? We're going to define impairment and then look very briefly at addiction. How do I know if I'm just using alcohol or drugs, abusing it, or addicted? We're going to spend just a couple minutes on that. We're going to then look at the red flags that might suggest one of your colleagues may be struggling with an addiction. These are the things that you'll begin to see in the workplace. And then specifically, you can also look at the red flags about diversion. And then we're going to talk about ISNAP, why participate in ISNAP, how do we work with the Attorney General's Office and the State Board of Nursing. And then lastly, we're going to talk about professional enabling and how even in organizations we enable our colleagues to continue on in their addictive process. So why are nurses at a greater risk? Obviously, the first answer to that question is fairly obvious. Easy access and availability. Kind of like a kid in a candy store. Now, we put things into place that make it more difficult. The PICSA system, obviously all of our patients are banded and you have to scan 2 or 3 times when you give controlled substances. So if medications do come up missing, it's sometimes a little easier to trace where those medications may have gone to. And yet, if you want drugs, what better place to work than a hospital or nursing home setting? So easy access and availability. Second reason I think why nurses are at a greater risk is what I call pharmaceutical knowledge or optimism. You know, as nurses, as health professions, we know exactly what drugs do. We know pharmacology. We know that if we use some medications over a given period of time, we might become physically addicted to it. And therefore, since I know better, it won't happen to me, right? Wrong. But that's that adolescent thinking that it's not going to happen to me because I'm a nurse and I know better. Thirdly is what I call the Florence Nightingale complex. Nurses are taught to do what? Give 110%, go the extra mile. We're always giving and giving and giving to our patients. So you just worked a 12-hour shift. There's a snowstorm or a colleague calls in sick, so your supervisor comes to you and asks you to do what? Stay over, work another 4 hours. Now that's part of this industry. That's to be expected on occasion. But at least what we experience with our ISNAP nurses is they don't do a very good job of saying no and of taking care of themselves. And if you're not taking care of yourselves, if you're always taking care of the patient, who's at risk? Thirdly is burnout. Anybody deny that working in healthcare today is a pretty high stressful environment? And if we, again, aren't finding balance in our life and we're not taking care of ourselves, there's a tendency towards burnout with the stress that we experience every day. And it's a cumulative process. There's a quote out of the Annals of International Medicine that says, then one of the more serious consequences of burnout is a tendency towards a substance use disorder. And this is where I talk about an estimated 13 to 14% of health professions struggle with this addiction. Where do you think the highest prevalency rate is in what specialty field? Anesthesiology and nurse anesthetist. As high as 20% struggle with a chemical addiction in those fields. So we're especially careful when we're working with a nurse anesthetist. Okay. Well, how do you get started to use in the first place? No person starts out stating, one day I'm going to become an addict. It starts out pretty innocently. The most common reason is the reason of Linda that I read. Linda had a bad back. Simply pain issues. After you worked as a nurse for a number of years, it starts to take a toll with all the lifting and everything that you do. So we begin to experience a lot of back pain, a lot of fibromyalgia, a lot of other physical issues where people are going to the physician and they're being prescribed a controlled substance for pain, legitimately. However, what happens is over a given period of time, they continue to receive their Vicodin, and I think they've pretty much convinced themselves that they need it. They think the pain is still very real, but for the most part, it also becomes a way of dealing with some emotional pain. It helps them to get through the day. It helps to ease their anxiety and their stress and tension. And so what started out as used for a legitimate reason, a prescription, ends up continuing on for other reasons. And there's the chronic overwork and fatigue. Again, you're working long hours. You've come in, you've worked 10 hours of a 12-hour shift, and you start nodding off. So what do you do to kind of give yourself that extra oomph? Or you come in and you know, as a parent and you're parenting and you come in and you've only had 3, 4, 5 hours of sleep and you're just running slow, we're feeling fatigue. And so we'll take something to help with our fatigue and to keep us going. There's the chronic stress and dealing with stress and anxiety. And a lot of times what we experience with our nurses is that life gets busy, they start to experience depression, they start to experience anxiety, and rather than take the time to see a therapist or take the time to go and see a doctor, what do? On occasion, they write a prescription for themselves, or they begin to self-medicate and get medications from colleagues or whatever, and we get a number of referrals because of fraudulent script writing, either for themselves or for somebody else. And I think it's a way of self-medicating their depression and their anxiety. And then oftentimes it just gets started for pleasure, especially alcohol. It's acceptable, it's legal, it's socially encouraged. The only thing I caution here is that addiction is a genetic disease. It runs in families. So if you have a family member, a parent, or somebody who's struggling with addiction, you just have more of a likelihood to develop that disease like you would with any other disease process. Okay, well, let's move on and define impairment. What does it mean to be impaired? As mentioned, this is a state statute legislated program. It's been in effect for 15 or 16 years. These are just the statutes if you'd like to go ahead and read those for yourself. Generic definition of impairment is nursing behaviors or conduct failing to meet the minimal standards of acceptable and prevailing nursing practice, which could then jeopardize the health, safety, and welfare of the public. My guess is when you hire somebody here at the community hospital, you want to hire the cream of the crop. You expect them obviously to perform above minimal standards. But when somebody begins to fall below minimal standards and they're not doing their job, something's not right. In our discussion this afternoon, it's secondary to alcohol or drugs. About 70% of all the cases that come before the Board of Nursing are alcohol or drug related. So they do tend to be the higher percentage of cases coming before the board, but they're surely not all the reasons that people are coming before the Board of Nursing. So it's an impairment that's caused either by the use or abuse of alcohol or other drugs. Impairment may be, but it's not limited to the following. This first clause is pretty much a generic clause, and so I'm not going to give any explanation to that in and of itself. What do you think the number one reason is that a nurse gets referred to ISNAP, or one of two number one reasons? At the end of the day, what's wrong in the workplace? Well, that may be the case too, but generally that's not the reason why we would see them. At the end of the day, their medication counts are off. Missing medications, suspected diversion. Occasionally it's admitted diversion, but for the most part, if somebody's in the throes of their addiction, they're going to minimize and or deny that they diverted those medications. So then obviously you have to begin some kind of an investigation to see if somebody may have diverted those medications. Now, I should mention that a number of nurses get referred to us for missing medications. They get referred out for an assessment, and truly what's assessed is that it simply was a medication error. They have no history of diversion, they have no history of use or abuse of prescription medications, and so it's truly a medication error, and we would simply state that they don't meet criteria for monitoring with ISNAP. We did have one nurse who had over 3-month period of time had like 13 or 14 situations where there were medication errors. That was significant enough that we wanted to bring her in. I think we brought her in for a year just to make sure that in fact it was simply a medication error and that she wasn't diverting those medications. However, if I did divert medications, I'm going to obviously try to cover up my past so that I don't get found out. So I may falsify records, I may omit records, I may pretend that somebody witnessed those wastes with me and actually put down their initials that they witnessed those wastes. And again, in a busy environment, nobody really checks twice until a red flag is raised. And then you go back and the nursing supervisor comes and begins the investigation, and then they may come to you and say, it says on this day that you witnessed these medications. And you say, I didn't even work that day. And then through the investigation, it's determined that in fact they were falsifying the record to try to cover up diverting of the medication. So the number one reason is suspected diversion that folks get referred to ISNAP. Obviously, any kind of abuse is impairment, whether it's verbal, physical, emotional, or sexual. A couple of examples that come to mind. We had a guy who was working in a nursing home. He was the only RN assigned to, I think, 30 or 35 patients. And he had a gal who had been in the nursing home for traumatic brain injury. She had been in a car accident and experienced traumatic brain injury. And what she would do throughout the day is self-harm. She would hit herself, she'd scratch herself, she'd bite herself. And after about 10, 12 hours, he was just totally exhausted and said, sweetie, if you don't stop doing that, I'm going to pull your arms off. Poor choice of words, verbal abuse. I think another family member or somebody heard the words that he had chosen, referred him to the Board of Nursing. I believe the nursing board really just believed that he was exhausted and it was, in fact, just a poor choice of words, and he may have gotten a written warning or something of that nature. Another example is a gal who worked in an adolescent boys' home. Now, boys who are in these homes generally have some difficulty controlling their emotions. There was this one morning where this kid was out of control, and so to protect him and others around him, they had him in a 3-point restraint. Well, he didn't like it. And so what do you suppose he did? Well, there's not too much you can do if you've got 3 people sitting at you. Well, he spit in one of the nurses' faces. She didn't like it. And what do you suppose she did? Spit back would have been nice. She literally hit it. They did it for cause urine drug screen. It was positive for alcohol. I think at a blood alcohol level of 0.06. She was referred to the Board of Nursing into ISNAP, diagnosed with alcohol abuse. Came in, I think, for a year, fully compliant, and then after the year, she went back before the board and had the probation lifted on her license, but it was for, obviously, physical abuse. Abandonment. We talked about, Linda with the bad back who couldn't get up to assist. Leaving the unit, not telling your supervisor where you're going. While you're gone, something happens to one of your patients. Going out to the car during lunch break, maybe dozing off, falling asleep, coming back 15, 20 minutes late. And then you may begin to see a pattern of attendance issues where people are coming into work late, coming back to work after a break late or whatever. Also patient abandonment. You don't see a lot of neglect in hospital settings. We do see some neglect in nursing home settings, but patient abandonment obviously would be impairment where you're not available to provide services when the services are needed. Delegating nursing care function, tasks, or responsibilities to others when the nurse knows that such delegation may be a detriment to the patient. The only caution here is as an RN, you're obviously given the ability to delegate responsibilities. If you do so, just make sure the person you're delegating those responsibilities to are either certified or licensed or able to do the skills that you're asking them to do. Again, more commonly, we see this in nursing homes where, again, I'm the only RN for 30, 35 patients. I might pull out the medications from the NARC box, but then I have my patient assistants help to give out those medications, but at the end of the day, if those counts are off, whose license is at risk? It's my license, not the person you've asked to do that. So just be careful that if you do delegate, that they're able to do what you're asking them to do. Diverting prescription drugs. Now, I used to think if somebody diverted medications, it was for their own personal use. But having worked in this field for 16 years, I've discovered that that's not always the case. A couple of other examples. Again, say you're living at home, you're living with somebody with real depression, real anxiety, it breaks your heart, and so you may divert an antidepressant or an anti-anxiety medication to take home for them. Maybe you're living at home with an addict. They've exhausted all the resources in the community. No other physicians are willing to prescribe any more controlled substances. So they say, hey, you go into the hospital every day, bring me something home. And so to keep peace in the family, what do? Now, that's codependency at its worst, but in fact, we've seen it happen more often than you think. Worst case scenario of diverting is diverting for what? Sale. We had a gal who was in monitoring with us, I think for 7 months. She was fully compliant, always had negative urine drug screens. She went to see her addictionist, and there was just something that didn't feel right, so we decided to run an inspect report. It's a pharmacy report that lists all the physicians who prescribed controlled substances over the past year, the pharmacy that filled those, and discovered that over a 7-month period of time she had over 2,500 Vicodin prescribed to her. Pretty egregious, so we closed her file and sent it on to the Attorney General's office. What do you suppose their conclusion was? She was selling that. According to statute, if it's determined that you're diverting for sale, your license will be revoked without question. Misappropriating money, obviously diverting is stealing. That's misappropriating property. Worst case scenario is we had a gal who was a cocaine addict, was working, had an elderly gentleman who was dying, and so in her clouded thinking, she thought, well, I'll just go ahead and take his credit card, use it to supply herself with cocaine, and in the death process, the family wouldn't really notice. Well, 2 mistakes. Number 1, he didn't die. Number 2, the family did notice. She went before the board. Her license was suspended. Got into ISNAP, diagnosed with cocaine dependence. Had a year's full compliance. Went back before the board. Had her license reinstated on a probationary status. 2 years later, she successfully completed ISNAP. They went back before the board and had the probation lifted. So what started out as a pretty ugly beginning with stealing a credit card ended up with a nurse saving her career, in part, I think, due to ISNAP. Performing any nursing technique or procedure for which the nurse is unprepared by education or experience. The only caution here is if you're asked to do something and it's a new piece of equipment or it's something that you haven't done in a long time, don't let pride get in your way, ask for help. Because if you go in and in the procedure something goes wrong, saying, oops, I didn't quite know how to do that, or I've never done it on this equipment before, it will be seen as impairment. So just make sure that you're able to perform whatever it is that you're doing. Disregarding a patient's dignity, right to privacy and confidentiality. A number of nurses get referred to ISNAP for HIPAA, not to ISNAP as much as to the Board of Nursing for HIPAA violations. Simply talking about patients' care and ear's length of other family members, accessing records without authority, et cetera, et cetera. So just make sure you guard their dignity and their confidentiality. And lastly, failing to provide nursing care because of diagnosis, age, sex, creed, or color. My younger sister went back and became a nurse when she was 35. Today she works in a hospital emergency room in Minneapolis, tends to work the weekend midnight options. So who do you suppose the number 1 patient coming in on a Saturday night about 1 in the morning is? Probably somebody drunk, drug seeking. My only challenge to her is I said, when they come in, and she said, generally we know exactly what they're there for. I say, do you treat them with the same compassion and dignity that you do anybody else coming into your ER simply because they have a disease of addiction? And I would hope so, that we're treating our patients, even though we know they may be alcoholic or addicted to drugs, with that same dignity and respect. All right. Well, very briefly, what's addiction? How do I know if I'm an addict, using, abusing, or dependent? Now, if you drink or if you take a drug, what do you have to do next month to get the same desired effect? Drink more. Increase. First of all, a nurse is defined as being dependent if he or she meets 3 or more of the following This is according to DSM-4. I have to update this because I think DSM-5 is going into effect here in October, or I think we've got until the first of the year. So increased tolerance. Take away that drug, what's going to happen? You're going to go into physical withdrawal. If you work med-surg, you'll probably see that quite often. Someone who's come in 24, 48 hours later, they're doing what? Seizuring, going into DTs because the supply has been taken from them. Most addicts, I think, begin to get a sense that, it's kind of drinking a little bit more than I should. Beginning to sense a little bit of loss of control, so I'm going to just watch it. So we begin to experience loss of control because we're using for longer than intended. We're going to cut down, we're going to stop, we're going to control our drinking. Addicts, for the most part, can cut down and control their drinking for short periods of time. It's usually over a given period of time that you might then see them going back into repeated behaviors. So they experience unsuccessful efforts to cut down or control use where their cravings are stronger than their ability because they don't have any resources to say no. Considerable more time is spent now either obtaining or the drug or recovering from its effects. Obviously, the compulsive use leads to more and more time now is spent with alcohol or drugs than it is with other things that are important to you. So the next one is other important things in your life are becoming less important. So now you're beginning to experience problems in relationships, going through a divorce, maybe losing jobs because of attendance issues, et cetera, et cetera. Oftentimes the question is asked of the nursing board, what I do in my own time is my own business. So if I happen to go out on a Thursday night and do a little too much drinking and get pulled over for a DUI on my way home, and I don't have to be to work until next Tuesday or Wednesday morning, what business is that of yours? Bug off. They probably wouldn't say it in those words, but what do you think the nursing board's response is to that kind of thinking? You're a nurse 24/7. And what you do on your off time reflects who you are as a nurse. So it is our concern. Plus, we do know that as this disease does progress, eventually it is going to begin to rear its ugly head into the workplace. It's amazing how well they can keep it covered up for weeks, months, even years, but eventually, if they don't arrest their disease, it will begin to show up in the workplace. And then lastly, continued use despite knowledge of problems caused or aggravated by use, such as a DUI. If I get a DUI, does that mean I'm an alcoholic? No. In monitoring circles, we call it struck stupid. Obviously, you were invited out for dinner, maybe you had a bachelorette party, and you went, you had a good time, alcohol was served. Your biggest mistake of the night was thinking you could drive home, so you get in your car, you fishtail or whatever, you get pulled over and you blow a .12. So, you get referred to ISNAP because you go before the board for a personal appearance. And I should mention that this is the second most common reason that somebody gets referred to ISNAP, alcohol related. Usually it's the DUI during personal renewal time. Sometimes it's going into work with the smell of alcohol on your breath, or doing it for cause urine drug screen and having a blood alcohol level of .06 or whatever. When I first started working in this field, there was a wise old counselor who said, there's 3 cardinal rules about an addict that you need to know. Do you know what those 3 cardinal rules are? They lie, they lie, they lie. Nicer put is they minimize, they rationalize, they excuse, they sweet talk. They'll convince you that this will never happen again. So if we get a person referred to us for a one-time DUI, but they had a relatively high blood alcohol level, we might suggest that they come into ISNAP for 6 months. Now, for 6 months you can't drink because we're an abstinence-based program. So if I knew that my nursing license was on the line, do you think for 6 months I could say I'm not going to even touch alcohol to take a chance? Well, I would say during that 6-month period of time, about 20% of those who come in for that rule-out diagnosis get a positive urine drug screen for alcohol. What does that tell you? Continued use despite negative consequences, and most likely it is indeed a bigger problem than they wanted us to believe in the first place. 3 or more of these 7 symptoms, you'd be diagnosed with dependence, come into a 3-year RMA. 1 or 2 of those, you'd probably be diagnosed with abuse, come into a 12-month or 18-month RMA, and then if it struck stupid, like I say, maybe a 6-month RMA. Okay. Now, we're going to shift and talk about red flags. These are the things that you might begin to see in the workplace that suggest a colleague might be struggling with a chemical addiction. First one is change in personal appearance of the workstation. Someone who always came into work, was always impeccably dressed, hair combed, makeup on, but over time, that begins to change. Their hair isn't combed, their makeup isn't on. Maybe they come into work one day and it's almost like, did you even get out of your scrubs when you got up this morning because it's just all so wrinkled? Worst case scenario was a guy who came into work with his scrubs on backwards. And I always get a chuckle, but how many think that he may have been some other signs or symptoms before this that he could have been reported to ISNAP? Without a doubt. True story, 6 months later, he was dead. Was an ISNAP, relapsed. He relapsed doesn't really surprise us because it's part of this disease. But during his relapse, he actually aspirated on his own vomit and choked to death. We have at least 3 or 4 nurses a year who die while in monitoring. We're not always sure of the cause. Usually it's an overdose. We don't know if it's intentional or unintentional. But this is a deadly disease, and it's taking away many of our precious nurses who really love what they're doing to the workstation. The other things you might look for is dilated pupils a lot. Nose is beginning to get a little bit more enlarged, or maybe the red veins are beginning to protrude. Skin color is beginning to change, and they're always palmy or sweaty. Coming into work, middle of summer, wearing long sleeve shirts, probably or possibly trying to cover up needle tracks or something of that nature. Then there's a smell of alcohol or marijuana on the person. Now, as I mentioned, addicts are generally very smart. So how many are going to come into work with the smell of alcohol? Or say you go out into your car during your lunch break and you smoke a marijuana joint. What are you going to do before you come back into the workplace? Cover it up. Mouthwashes, mints, perfumes, anything to cover up the smell of alcohol or marijuana or whatever. We had this one nurse, we got a positive urine drug screen for alcohol. The first thing we do is we call the workplace and say we have this positive urine screen for alcohol. And when it's alcohol, we don't immediately pull him off work. We want to kind of see what's going on because there are a couple of things that will cause a false positive for alcohol. Say you're diabetic, spilling sugar in the urine. From your collection site to the lab up in Lebanon that does our testing, 3 days it could ferment. And so generally we discuss it with the worksite monitor, and she said, no, she's my best nurse. I've never had any concerns. 2 hours later she called us back and said, you know, I've been giving it a lot of thought, and the last 3 weeks she has been coming to work with a more pronounced smell of perfume. She finally admitted to relapse, and what she was doing is using the perfume to cover it up. Speech is affected. Somebody comes into morning report, they start giving morning report, they're talking so quickly can't understand what they're saying. Or maybe they're garbled and it's very difficult to get words out. Something's not right. Did they get a new prescription that they've added to the one that they're currently taking, and is the cross tolerance causing some problems with their speech, or are they using or abusing drugs? So the speech can, and even if people are calling in sick, take note of their speech patterns because that can be somewhat telling. Inability to focus on work, distracted, flitting from one thing to the next. You're always kind of coming behind them and saying, whoa, you got to go back and do this. You forgot the chart that you called the doctor or whatever, because they're just not staying focused on work. We talked a little bit about missing in action, a pattern of frequent trips to the bathroom after giving out the controlled substances, going out into the parking lot, coming back from noon out from their lunch break late, the Monday morning flu after they've had an extended period of time off, a pattern of calling in sick, not being available when they're on call. Now, my guess is if you're a supervisor and you're on call, you need to be available 24/7. We had a nurse in monitoring. She was on call. She got called into work. Immediately she went into work, and as soon as they got into work, they smelled alcohol on her breath. Obviously, number one, she was on call. She shouldn't be drinking. Number two, she was in monitoring with ISNAP, and obviously had not gotten a hold of her addiction, and pulled her off work, got her into a higher level of treatment, and then got her back to work when she was ready. Rapid mood swings. Somebody who comes into work in the morning and they're just moving like a turtle, slower than all get out, and 2 hours later they're going a mile a minute and they're accomplishing more than you can imagine. Or they come into work and they're grumpy and it's like, whoa, don't go near Sally today. 2 hours later she's sweeter than pie. What changed her mood in such a significantly short period of time? Sleepiness, drowsiness, nodding off at the computer when they're putting in their progress notes or whatever. And now again, if somebody was up all night with a child, didn't get any sleep, and come into work, occasionally this is going to happen. But you might begin to see a pattern where it's happening more now, more frequently. Well, we've had a couple of nurses who've been referred to us because not only do they nod off, but it's very difficult to even get them to wake up and to respond. Again, are they just on some new medication that may cause this drowsiness? Or are they drinking on top of or taking additional medications to the one they may be prescribed or whatever? Impaired balance, coordination, kind of walking into things, tripping over their own 2 feet, not very steady on their feet might be a symptom that something's not right. Talking a mile a minute but not making much sense, not being very cohesive. Unusual energy, nervousness, anxiousness. Again, that's not typical behavior for them. Unusual or unexplained resistance to authority. I'll come back to this when we talk about diversion. Deviating from standard procedures, not following the way it should be done. We had a guy who came in before the Board of Nursing because he simply wasn't getting somebody to witness the waste. This was his explanation. He said, okay, I had a choice here. He said, I'm the only nurse in a nursing home, again, kind of a common theme. I had 30 patients. Now, do you want me to make sure that they're all getting their medications, they're all getting their treatments, they're getting the proper care, or do you want me to traipse around and try to find someone to witness the waste? What do you want me to do? Sounds a little logical, right? Well, what we really want you to do is find someone to witness the waste. And if it really is a staffing issue, then that really becomes an administrative issue that has to be dealt with. We have on occasion counseled some of our ISNAP nurses to consider leaving a position if they're being placed in a position where they're putting their license at risk, where in fact they're understaffed or asked to do things that really is impossible for one person during a shift or whatever. So anyhow, deviating from the way things should be done, not following standard procedure. Illogical or sloppy charting. Again, as nurses, we know that if it's not charted, it didn't happen. And then if it's charted, but it doesn't make any sense, or you're forgetting to chart that you called the physician, you got the orders, you called the family member, whatever, if it's not charted, it didn't happen. And it could be a possible sign of an impairment that you're not completing all the charting that needs to be done. Now you're beginning to make errors in judgment, and what's beginning to happen? You're beginning to fall below minimal standards of acceptable and prevailing nursing practice. You're simply not doing your job. On occasions, it's been determined that a nurse just really does not fit that position. It's been assessed that they don't have a substance use disorder. It simply wasn't a good match. They didn't have the proper skills to do what they were being asked, etc. So again, I reiterate that not all impairment is secondary to alcohol or drugs. You might begin to get to more and more complaints about personal interactions, either from patients who are complaining about the nurse's bedside manners and they're not being treated very kindly and they're being barked at or whatever, or colleagues are beginning to complain, don't assign me with so-and-so, I won't work with him. It's just too difficult. So you're beginning to get more and more complaints. We talked about the inaccessibility, consistently signing out more controlled substances on his or her own shift. We get a lot of referrals from community security officers, people running quality assurance. They simply run reports. And after the report, they discover that anytime Jane works, acuity care is the same, patient load is the same. The only thing that's different is more controlled substances are going out when Jane works. Now, what does that mean? Does it mean Jane is just more compassionate than other nurses and can't stand a patient being in pain and might fudge the rules and give out a handful more controlled substances? Or it might mean that, in fact, he or she is taking them for their own personal use. Frequent breaks or altering of vials. Spilling drugs, we don't see that too much anymore because they're now in aluminum packs. When they used to be in pill bottles, you could spill a bottle of 30 pills and they'd go rolling all over the place. It'd be easy to pick up 20, put them in a pill bottle, put 5 in your pocket, and no one would know the difference. We had a nurse anesthetist in monitoring, and her worksite monitor called us and said, "Do you guys test for fentanyl?" And we said, "Well, yeah, we don't generally, because just to test for fentanyl alone, it costs another $75 or so for the urine drug screen. At least in the past, fentanyl wasn't as common. Now, that's not true anymore. With the fentanyl patches, et cetera, we're beginning to see a significant increase in the abuse of fentanyl." But anyhow, we said, "Why?" They said, "Well, we have this vial. It looks like she took the top of the vial off and may have taken out the fentanyl and added, substituted saline solution." So we said, test her on the spot. Tested her. What do you suppose the results came back positive for? Fentanyl. The only reason to believe that was an altered vial. Waiting to be alone to open up the NARC cabinet again. You want your other colleagues to be out passing their NARCs when you enter the PIXA system or whatever, so you may not be noticed if you're trying to take out additional. Nursing homes, sometimes they assign nurses to give out the controlled substances, and you may have a nurse who's a little too anxious to volunteer to be that nurse. A pattern, again, of disappearing into the bathroom after you've given out the controlled substances. Ordering medication from the pharmacy prior to the refill date. Life gets busy on med-surg units and on post-surgical units. And basically, you send down an order to the pharmacy fills it, they send it back, and oftentimes, unless something comes up that's questionable, you're never discovered. But then when something does come back, you find out that, hey, this person is actually ordering medications from the pharmacy prior to the refill date, or even worse, they're ordering for patients who were discharged or died this morning. And then this order came in this afternoon. And again, sometimes they get away with this because it's just so busy and nobody notices it until there's some suspicion, and then you go back and look at the records more carefully. Or occasionally a pharmacist then will become suspicious if they begin to see a pattern, and then they'll call the unit and begin to investigate. Unexplained changes in the route of administration. Again, discrepancies in the PIXA system itself. NARC counts are off at the end of the day. You're not getting those co-signatures. Discrepancies between a patient's report of pain relief and what's documented. So you're an afternoon nurse. You come in at 3:30. You go into your first patient and they say, "God, my back is killing me. Can I get a pain pill?" So you look at the record and they've just given something an hour ago, and you say, "Hon, I really have to wait, and for whatever period of time that it is that you have to wait before you can give something." Now, they were given something an hour ago, but what was it? It was Tylenol. It was a PRN medication rather than the Tylenol with codeine. They don't know the difference between Tylenol and Tylenol with codeine. The only thing that they know is that the relief they didn't get any pain relief from the medication that was given to them. So you might begin to see an excessive use of some PRN medications. And we talked about that. Hanging around. Occasionally a nurse has been caught going through the physician lockers, especially in surgery or whatever. We don't see that too much anymore. One pattern that we're beginning to see a little bit more of is nurses are going through other nurses' belongings in staff lounges. Say I come in one morning and I say, "God, I had such a toothache last night. I went to the emergency dentist and he gave me 30 Vicodin until I could go in and see my own dentist to get a root canal." Now, if I'm an addict, what did I just hear? 30 Vicodin. And so when you're out passing your medications or whatever, I'm going through your purse to see if, in fact, I could just borrow 5 of those 30 Vicodin and you'd never know the difference. I said I'd come back to this when we talked about diversion. Defensive when questioned. Now, suppose at the end of the day, as a supervisor, you go up to a colleague, or as a colleague, you go to your supervisor and they say, we got a problem here. We're missing a couple of Darvocet or Vicodin or whatever. What would your reaction be? Wow, it was a busy day. Maybe I just forgot to transpose something, to chart something, to chart it out. Let's go back and see if we can find out where they went missing. Now, if I just diverted those 2 medications, what do you think my reaction might be? Give me a break. You're always riding me. You're always on my back. Anytime you need someone to come in to pull an extra shift, I'm the first person to volunteer. And then when a couple of pills come up missing, you blame me. So they're much more defensive in the missing medication that's come up on the unit. So that might just be, again, another clue. So if you begin to see 2 or 3 of these kinds of behaviors, surely it's a red flag that you might want to begin to observe them more carefully, begin to do an investigation, look at some of their records, et cetera, to see if, in fact, there might be some diversion going on. We're an abstinence-based program by state statute, which simply means that if you're in monitoring with ISNAP, obviously you can't drink, you can't use illegal drugs, and if you do use legal drugs, they have to be prescribed and for a very, very short period of time. We begin occasionally to see the pattern of a nurse who, we get a positive urine drug screen, we call up the nurse, oh, I forgot to tell you, I sprained my ankle, went into the ER, the doctor prescribed Vicodin. 3 months later, we get another positive, this time for Lortab or Tramadol or something like that. We call the nurse, whoops, I forgot to tell you, I slipped or whatever, went to the doctor. Now, we always instruct our participants, you need to inform us at the time or ahead of time and provide us a copy of the prescription. So when we begin to see this 2 or 3 times in a row, we begin to question, is this actually more drug-seeking behavior than it is behavior that's necessary for whatever medically might be going on with that right now. All right, very quickly, who is ISNAP? How do we work with the Attorney General's office, etc.? We have 2 primary goals. This is the reason why it's written into law. First one, of course, is public safety. The state of Indiana wants to make sure that if a nurse is impaired with a substance use disorder, they're safe to practice. And secondly, we do want to do what we can to try to save their career, get them into recovery, and get them back doing what they love. We monitor the process by referring them to ISNAP. And then the other thing then that ISNAP will do for the nurse is advocate for the nurse. How many here have been down to the board hearings on the 3rd Thursday of the month? I'll recommend that once a year they try to bring the board hearings to different parts of the state. This last year we just did it at Fort Wayne. I will recommend that next year we try to bring it up here to Northwest Indiana. It's a fascinating experience. 9 members have been appointed by the governor to sit on the Board of Nursing. 8 nurses and a community member. She's actually an engineer for Cummings, and you get an interesting perspective from somebody who's looking at from eyes other than a nurse. Now, there's 2 tables before the Board of Nursing. The board acts as the judge. In one table, the Attorney General sits at, and the other table, the nurse sits at. If I'm the Attorney General over here, I'm going to try to convince the Board of Nursing that this nurse is not safe to practice. Of course, if I'm the poor nurse sitting over here, I'm going to try to convince the board that I've not done anything that would convince the board that I'm an imminent risk to public safety. If I'm sitting with the board or with the Attorney General, unfortunately, I'm going to probably be testifying that this nurse is in non-compliance, they've been closed out of ISNAP, they've had more than 1 relapse or whatever. However, if I'm sitting over here with the nurse, I'm going to simply be testifying that the nurse is in full compliance and recommending that their license be reinstated or that their probation be lifted from their license. So we do a lot of advocating for the nurse. Why participate? Again, we're administered by the Indiana State Nurses Association. We have nurses on our staff. We're an alternative to discipline. We're not a guarantee that if you come into ISNAP, there wouldn't be discipline on your license. If you self-report, there's been no formal complaint, your referral to ISNAP goes nowhere except with ISNAP and obviously the worksite monitor. Unless you become non-compliant or you experience more than one relapse, at which time we're committed to the board to refer that person to the Board of Nursing. However, if you self-report, but there was also a formal complaint that was registered by the facility for diversion or whatever, then of course the Attorney General is going to continue to follow up with that investigation, and you're simply being an ISNAP because you did it before they finished their investigation isn't a guarantee that there may not be action against your license. However, there's a better chance that there won't be any action taken against your license. RN just renewed this last September, October. This last Wednesday and Thursday, we saw over 350 nurses for a personal appearance because they checked yes to one of the 6 questions. The 2 questions that get most response from a nurse having to come before the board for a personal appearance. One is, since you last renewed, have you been terminated, reprimanded, disciplined, or demoted in the scope of practice as a nurse? And if you have, even for attendance, you'd have to check yes, and then before your license is renewed, you'd have to come before the board for a personal appearance. The second most common reason is, since you last renewed, and except for minor violations of traffic laws resulting in fines and arrests, have you been convicted, or have you been expunged by a court? Have you been arrested, entered into a diversion agreement, been convicted of, pled guilty to, or pled nolo contender to any offense, misdemeanor, or felony? What I would recommend is that if you get a DUI, if you get any kind of criminal offense, and it's alcohol or drug related, self-report to ISNAP. Then when you do go before the board for a personal appearance in 2 years, they are more likely to renew your license free and clear. Those 350 nurses, anybody who was an ISNAP and fully compliant, they simply renewed their license free and clear. For the nurse who waited for the renewal process to check yes on the DUI, their license was placed on indefinite probation, and then they're referred to ISNAP to determine if they meet criteria or not. But their not licensed now has been placed on probation, and that unfortunately becomes a permanent part of your record. So it's always better to self-report before you go for personal appearances at renewal time. Are you obligated to report if you suspect a nurse may be impaired, simply not doing his or her job? And yes, you are. By state statute, you can report to your supervisor, your manager, to employee assistants, to human resources, and you've fulfilled your obligation, but you are obligated to report if somebody is impaired or not doing their job. I'm surely not going to have time to talk about professional enabling, but I'll just make a comment here that, in fact, it's more caring and loving to actually confront or carefront a nurse who you think may be struggling with some kind of a personal and or issue with alcohol or drugs than to simply sweep it under the rug, hope it's going to go away, or believe there are many excuses that I'm just going through a rough time, it's going to get better, whatever. It's always better to address the issue directly and honestly at the time that it's happening than to wait until the disease continues to progress and then something does happen which will in fact put their license at jeopardy. So it's always better to report than it is to not. Very quickly, basically, how does it work? A nurse is referred to us, either they're sitting in the office with their EAP, with human resources, with the supervisor. They call us, we do a brief intake, we send them out to an agency in the community where they live for an assessment, and then based on that assessment and diagnosis, they enter into what's called a Recovery Monitoring Agreement, RMA. And the RMA has these conditions. We're an abstinence-based program. Best way to determine if someone's using or not using drugs is to have a pee in a cup. So every morning they have to call into an 800 number, or they can go online, see if they're scheduled to do a urine drug screen today. And at least once a month we use the old clause, and it must be observed. And why do you think we added that clause about a year and a half, 2 years ago? Well, unfortunately, there's a small handful of folks who are addicted who put more time and energy into staying sick than they do into getting well, and they can learn ways through the internet on how to beat the urine drug screening system. So at least it's a little better chance of catching that if in fact the urine drug screen is observed. The cardinal rule of monitoring is worksite monitoring. Anybody who's in monitoring with ISNAP must inform the workplace and identify generally their immediate supervisor, sign a release so that we can be in touch with that person. They become our pair of eyes and ears in the workplace, so if they have a concern, they call us. And likewise, if we have a concern, if we get a positive urine drug screen, the first person we're going to call is that worksite monitor to determine if we should pull them off work, if there's any concerns in the workplace for impairment, etc. We also try to create as safe an environment as possible. So if somebody's been diverting and is addicted to opiates, when they first go back to work, we're going to limit access to controlled substances, no access for the first 6 months that they go back into the workplace. We're also going to try to restrict working a regular 40-hour work week rather than overtime, because generally when they're doing in monitoring, they're going to meetings, they're going to their therapy groups, et cetera, and we don't want them to overextend. We generally don't approve positions or working a midnight shift where there's no supervision, because we want to make sure there's adequate supervision for a nurse coming back into the workplace. We generally don't approve home health care initially when they first come into monitoring, because how do you monitor a nurse going in and out of multiple homes? So we try to create an environment that's going to be more conducive to them not falling back into old patterns and relapsing. And they obviously seek initial treatment when they first come into monitoring. They go to 12-step meetings. We get monthly reports from the nurse, and then we get quarterly reports from the worksite monitor, sponsor, addictionist, and therapist. And that's pretty much how we monitor our nurses. Again, I think I've talked very briefly about professional enabling. Just as families enable, so can organizations enable. Or otherwise, the other thing sometimes organizations will do is simply terminate and send them on their merry way and not do anything else. And then again, they're free to pretty much go on and for their disease to become uncorralled, so to speak. So again, the most caring thing to do is to address the issue honestly and upfront and refer them to ISNAP. And then we'll take over and make sure that if in fact they do have a substance use disorder, we're going to make sure that they get monitoring. And if they don't, we're going to make sure that they go before the Board of Nursing and they will have action taken against the license so that they aren't practicing as an impaired nurse.